Oh, it works too. Just half of
And
it.
you guys can see that I have things on the screen as well. So for once in my class, do not have a technology issue. This is the first time for the semester here. Okay. Except for that, we of course had the issue with the links. Did you guys all end up with working links? Chris Rand has been working with me to get it, so I apologize for the late time. I think that content on the slides and today you should be able to still handle whether or not you had a chance to watch the links, but of course, I give you lovely tips and tricks and say a lot of so definitely worth listening to. Okay, so how about we start with acute respiratory failure? So we'll go through and do these little cases. I will give you, it's like 25 minutes and see what happens, and if you're like, I'm nowhere near, then we'll do a little bit longer than that, and then we'll talk through it, and then we'll switch gears and talk about CKD. Sound like a good plan? Okay, awesome. So at 9:30, I will start making eyes at Augusta and see where we're at.
This in our topic.
If it's not, I feel like Kindle is about to put it in there.
Yeah.
Alrighty guys, in the interest of time, let's get moving on this. So, acute respiratory failure. We have patient BPM, 34-year-old male. He shows up with flu. He ends up getting intubated. What is going on with him? We'll just go in order today so you guys can count it out. Group 1, what do you think is going on with this guy?
We think it's respiratory acidosis.
Sure. Can you give me like a bigger picture, like what do you think the disease state is? I agree. He has something going on with his respiratory system.
He may have ARDS.
Yes, I agree. Tell me how you came to that lovely conclusion. What?
Yes, bilateral opacities.
Yes, he does have bilateral opacities. There's also the Berlin criteria. So what other Berlin criteria does he meet? Let's take a look. So the Berlin criteria have a couple of different things that are going on. So the first off is, does the timing make sense? So does he have a known clinical insult, and did that happen recently? So we're saying that he's had how many days? 4 days of not feeling that great. He has the flu. So we're within a week. So that sounds about right. He's got bilateral opacities, not fully explained by effusions or nodules. So what this is saying is someone who had like really bad lung cancer and was riddled on both sides, they could have bilateral opacities, but it's not ARDS. Similarly, if you get a decompensated heart failure patient that's 30 liters up, they will have a very fluffy bilateral looking picture as well, but it's not, again, ARDS. So he does have that going for him. Let's talk about the origin of edema. So again, it's not fully explained by cardiac failure or some of the fluid overload. Now the tricky part is that a patient that has heart failure could also have ARDS, and so that is kind of a really difficult picture of how do you say like, okay, they have heart failure, but we still think something else is going on with their lungs. But this guy's 34, previously healthy, so pretty sure he's got a normal EF. And then finally, tell me about his oxygenation ratio. Is he doing well or not well from this perspective? P to F ratio. Kind of like question 1A. How about group 2? What is this guy's P to F ratio? Or do you know how to calculate it when you start with that?
We calculated a PF ratio of 158.
Beautiful, yes. So if you look here at this criteria that are on the board, or if you Google it or find it in the PowerPoint, you have mild, which is 200 to 300, moderate, which is 100 to 200, and then less than 100 is severe. So again, if you're thinking about you, we're breathing 21% FiO2 right now. That's what's in the air, it's 21%. You guys probably heard that a normal O2 value on an ABG is 80 to 100. And so that works well with the ratio about 4 to 5 times the FiO2, which we project would be your PaO2. So similarly, if you took me right now, put me up to 100% oxygen. So I'm breathing nothing else in the air, just 100% FiO2. I have normal lungs. I'm a healthy adult female. If you took my blood gas, you would expect that I have a PO2 of 400 to 500. Okay. So when you're saying that this guy's on an FiO2 of 60%, who can do some quick math for me? What would you think that his PaO2 should be if he was normal? Thanks for whispering, it's okay.
240 to 300.
Yeah, 240 to 300. So, looking at this patient, so a normal FiO2 or a PaO2 you would expect would be 240 to 300. So at 95, he's like nowhere close to that, right? So we know something is not right. So, in these ways, I think that he does have criteria that fit this diagnosis very nicely. Fun facts about ARDS, there's a paper that came out about 8 months ago, and they basically showed that we get this wrong like more than half the time in terms of diagnosing. We're always really late. So this is a difficult diagnosis because the S in ARDS is syndrome. So you're looking at this constellation of pictures and saying like, okay, like this is all coming together. We think it might be ARDS, but we do a bad job of diagnosing this. So this is a frequent issue for us. Okay, so as we said, we think this P-to-F ratio should be 240. It's actually 158, so that's not very good. So what type of respiratory failure does he have? And then also tell me why. Group 3.
We got that it's a mixed hypoxic hypercapnic respiratory failure.
Yes. And why do you think it's hypercapnic? I agree with you. I just want to know how you got there.
High CO2?
Yes, absolutely. I'm not trying to trick you. I just want to make sure we're on the same page. If you're looking at CO2 saying that there's a problem with ventilation. So again, the way that I would think about the rest of today and just in general with thinking about respiratory issues is that you can almost decouple oxygenation and ventilation. So oxygenation is the breathing in part, it's the part where O2 is involved, that's your P to F ratio. Then on the other side we have ventilation, and that's going to be CO2 management. All right. Now of course, there's always some smart aleck that says, well, if you're not breathing at all, it's going to be both. And that's true. At some point, if you're not doing one, you're going to have a hard time doing the other. But you can have patients that have just hypercapnic respiratory failure, just hypoxic respiratory failure, and the other value is fine. Okay? But for him, he does have a mixed picture. So obviously, we have said the PO2 is low, so that makes sense. And he is also retaining CO2 at a 55. So we're not in a good place. All right. What do we think is the most likely cause of his hypoxia? And I want to know, like going back to the slide deck, like which of these 5 causes of hypoxia do you think it is for this guy? What have we got? 4?
We said it became mismatched.
Yes. Why do you think so? I agree with you. I just kind of want to know again what your thought process is.
Can we just say he has poor ventilation, possibly due to like the fluid?
Yeah, the fluid buildup from ARDS. So that's one of the classic parts of this, the exudative phase. Basically, you get this, neutrophil-rich gunk, if you will, in your lungs. So again, going through these, hypoventilation. I don't give you the values here, but I don't say anything about how he's not breathing. So as long as he's breathing normally, it's probably not hypoventilation. He's also 84 kilos, pretty standard weight, so I don't think he's got obesity-related hypoventilation or anything like that. Right to left shunt is like if you have like hole in your heart. We don't have any information on that going on. Diffusion impairment. There probably is a little bit of diffusion impairment here in that there is kind of this gunk that's in the system. So probably a little bit of that's playing into it. And reduced FiO2. This guy is not on Mount Everest. And in fact, we know his FiO2 is 60%. So he's 3 times the normal. And so classically, ARDS is definitely characterized by a VQ or ventilation perfusion mismatch. So you're basically putting air in a place where it can't get across, and you have limited blood flow in that area. Okay, so group 5. The respiratory rate's 22, tidal volume is 400. What is this patient's minute ventilation?
We got 8,800 milliliters per minute.
Perfect. And I would say that on the machine, it will be in liters per minute. So I usually see it as 8.8. So that is, but you did the math correctly, so congratulations to you. This is a nice number to be aware of when you're in an ICU setting because you will hear about it all the time on rounds, and it's helpful for you to be able to follow along because sometimes it also, they'll think that it's maybe a minute ventilation issue, but you think it's a drug-related issue, so it's nice to be able to know this value. So again, people really wanted minute ventilation to be a thing that we could like correlate with stuff, where they said, oh, it's 8.8 and therefore that's really good, or that it's 7 and that's really bad. And unfortunately, it's not a number that you can use like that. My minute ventilation might be almost double one of you sitting right there because I'm talking right now and we're both doing fine. So it's not super useful from that perspective. How it is useful in a trend for that patient based on their blood gas. So if his minute ventilation is 8.8 and his CO2 is high, and you know that you need to increase minute ventilation to reduce CO2, what would you want to do? You would hopefully see that we've done something to his respiratory rate or his tidal volume to increase that number. So hopefully tomorrow it's 10 or 11 or something. Similarly, you come in tomorrow and it's 6. You either have to hope that the CO2 has improved to the point that we've kind of just reduced his ventilator needs altogether, or that we've done something wrong. And then they start saying crazy stuff like, oh, they're not doing very well, we need to paralyze them. You're like, whoa, you know, we talked about this yesterday and somehow we made no moves, you know, are we sure? So that's kind of where it's helpful to be able to follow along, because at some point they're going to bring in some crazy pharmacotherapy. They want to use inhaled nitric oxide, and it's nice to understand the basics of where they're coming from before you agree or disagree with an expensive and invasive medication therapy. All right, so I kind of gave you the answer to this next one. So again, does this minute ventilation need to be increased or decreased to normalize the carbon dioxide? So if his CO2 is high at 55, what are we going to do to the minute ventilation? Increase it, absolutely. Okay. Perfect. So the next question, we observe the patient, they're fighting the vent, their eyes are open, they're gagging, they're pulling tidal volumes of 800, they seem not in a good place. So tell me what you think we need to do for this patient. What group are we on? 6? What are some pharmacologic options?
We thought he needed a higher level of sedation, also continuous analgesia with a fentanyl drip, and for the sedation, either propofol or midazolam.
Love it. I have almost nothing to add, but I'll give you some more commentary. That's a perfect answer. So one of the questions I had on the Augusta campus was, I don't know what to think of this 800 cc's. Is that normal? Is it not normal? So in ARDS in particular, the only study that's actually shown mortality benefit is a study about tidal volumes, and this tidal volumes were 6 cc's per kilo. Interestingly, this is a huge quality improvement measure where it's actually, although we know this, and it's the only thing that actually improves this, we do a terrible job of it. So there was actually a study that came out of this French pharmacist, and they have a checklist of things they do, and they look at all sorts of stuff, antibiotics, sedation, everything. But they also look at the 6 cc's per kilo, and they're, you know, anyone can do the math of a volume divided by a weight and say this is not the right number. Do we want to do something about it? So I've seen lots of quality improvement projects just from an ICU level about this number. So basically what this patient is doing, because they have air hunger, is that they are, if they kind of pull in with enough power when they're breathing, they can kind of like bite on the tube and like basically force the machine to give them air. We don't like them to do that. It's bad for the tubing, it's bad for the patient, and there's a lot of things that this is not good. So not only are they uncomfortable, but it's definitely going to actively mess up what we're trying to do from an oxygenation and ventilation standpoint. So I agree, we should definitely sedate this patient. So first off would be fentanyl, analgesia, so analogous sedation. See how that goes, and then likely this patient's going to need some propofol or some midazolam. Probably propofol being my preferred agent because it's a non-benzo agent for the CAD guidelines. But we could have a talk about midazolam. I can't necessarily stop you. The key thing here, we don't need to paralyze the patient right now. We have not reached that point, okay? Paralytics are a very invasive medication. They're very dangerous. They have a lot of adverse effects. So the adverse effects go from, I'll say, the legal, social aspect to just straight what happens to the body. So when you paralyze someone, especially if you give them steroids, you can see basically ICU-acquired weakness and myopathies where it actually like harms the muscle, and that they have significant weakness that's hard to come back from. You also are making it where they can't move, and so the big thing at SCCM right now is all about early mobility. Patients that walk do better. So they have patients that are on ECMO walking around, patients that are on ventilators walking around because they do so much better. Little stationary bikes where you like bike in the bed, all that kind of stuff. So they're paralyzed. We're not doing a good job from that perspective. The other part too is that the patient can't talk to you or interact with you, which can be a problem. So they can, if they're awake and alert to some extent, they can tell you what's going on, that they're in pain, that kind of thing. The other part that is very serious is if a patient were not sedated enough and they were awake, they would then basically be awake with no ability to move or communicate, which is pretty traumatizing. So if you want to read some like pretty scary stuff, you can look at like patient accounts of being paralyzed and awake, and there's like all these review papers of the comments and stuff, and it's like porn to be said, in my opinion, reading that. So we're gonna wait for the paralysis. Unfortunately, 30 seconds later, the patient ultimately did need to be paralyzed. But again, we did the right thing first, right? With fentanyl and some propofol and normodaxil. So we put him on CISAT for the AccuRaces trial. We know the patient's a train of 4, 0 out of 4. Is this normal? What's the target? Tell me a little bit about it. Group 7. What do you guys think?
We said no because any value below 2 out of 4 indicates overuse of a paralytic agent.
Yes. And what, so you said 2 out of 4 is maybe your goal, and what is normal, just to make sure we're all on the same page?
A 4 out of 4?
Correct. So if you go on rotation with me, you will definitely get to do this. And if you go with any ICU pharmacist, I would recommend asking, hey, can we find the train of 4 device? Because it's kind of interesting to show up. So you basically, it's like this little box, and then you have these electrodes, so you hook it up to yourself, and you basically turn it on, and it shocks you 4 times. So it feels kind of like if you shock yourself on a doorknob, but it's like directly on your nerve, so your hand literally twitches when it happens. So again, for me, I have no nerve conduction issues. I'm not paralyzed. So if you hooked me up and I twitched it, it would be shock 1, shock 2, shock 3, shock 4. 4 out of 4. That's normal. If it's 0 out of 4, you are way, way paralyzed. 2 out of 4 correlates with 90% of your junctions, I guess, being blocked. But what's interesting is that you can still twitch twice, which is pretty incredible, even though 90% kind of shows how effective your body truly is in some ways. So they have found that 2 out of 4 achieves most of the things we need to achieve from a ventilator standpoint, but again, we don't need to go all the way to that 100%. They have found that using train of 4 monitoring is it's actually interesting. There's controversy in the literature, but I think overall everyone would agree that by using this, we reduce how much neuromuscular blockade the patient is getting. It just hasn't had overall like these big long-term outcomes or something like that, which I think is kind of hard to see. A patient like this is very, very sick, but the fact that we can avoid overdoing it is helpful. So anyway, I highly recommend you can look it up on a YouTube video or try to do it on your rotations. It's very interesting. All right, the patient is very concerned, the team is concerned that the patient has renal and hepatic injury secondary to their critical illness. What do you think? Should we keep CISAT? Should we not? Tell me about that decision. Group 8.
Based on lexicon, there are no adjustments needed.
Absolutely. Do you know why? Because it's kind of a cool thing as to why. Let's see, is it
CISAT has Hoffman degradation.
Oh, beautiful. CISAT is one of my top 5 favorite drugs, particularly for this thing, for this characteristic. So CISAT is an amazing drug for this reason, and it's perfect for critical illness because as long as you're alive, you're going to have plasmapheresis. It'd be a pretty bad place for you to not have plasmapheresis. So Hoffman elimination is very helpful for this. There's also atracurium, which also goes by Hoffman elimination, so you could potentially use that. My program director was she said, I'm a big Atra girl. She likes atracurium because it's a little bit more cost effective than Cysat because it's generic. And she was not exactly a huge believer in some of the purported benefits of Cysat, which is that it has less lithanisine, it has less hypertension and some other things. I personally am a believer that I would like to use the agent that was in particular studied and showed mortality benefits. So the Accuraces trial with Cysat shows the benefit. It's never been done with atracurium or Beck or any of the other ones. But anyway, Hoffman elimination, stay the course. Okay, so you walk into the unit now, and you have two different scenarios looking at this little ventilator. Tell me which one you think is better for extubation and why. Group 9.
We said scenario 2 because the tidal volume is closer to a normal level than the first one, and low tidal volume is associated with improved mortality and improved time to extubation.
Ooh, I like that thought process in terms of the tidal volume, but I'm going to say that I personally like scenario 1 better, and I will walk you through it. Okay, so scenario 1 on my picture has an FiO2 of 30% compared to scenario 2, which has an FiO2 of 40%. So assuming that the patient has, that their blood gas looks normal, I would be happy to see a normal blood gas on a more normal FiO2. That to me speaks of good things. The next thing I would move over is that peak value, the positive end expiratory pressure. 10 is more than 8, so 10 is saying more support is being used right now. So again, we're saying that we have the same outcome, but we're using less FiO2 and less peak. I also admit the respiratory rate speaks to me a little bit more in scenario 1, in that it's 12 versus 22. 22 is like a lot of breaths per minute. I feel like if you were to put a stopwatch on and you make yourself breathe 22 times in a minute, you're not going to feel that great afterwards. It kind of shows that something is not right. Like you should either be like sprinting or something else is going on. So 12 is much more of a normal value. I do agree that the tidal volume of 450 versus 400 is a little bit like not super thrilled with that. But again, it might just be that this patient at this point is breathing on their own, and they're basically, that's kind of like where they're settling out. But to your point, this is definitely a doc on scenario 1. Other things that I like, which are a little bit more higher level, I suppose, would be the peak pressures. So the one is 17 versus 28. 28 is higher, and that means that they're having higher peak pressures in their lungs. And that to me kind of speaks of, do you have more stuff in there, like you have more gunk, and so when you're pulling in air, you're creating a higher pressure system? Are your lungs less compliant, more stiff? Those kinds of things. So lower peak pressures to me speak of like a happier lung. The other thing too is that the minute ventilation of 9.7 versus 9 is almost the same. And so I think we're looking at it from that perspective, I'm comfortable. The other thing that's kind of interesting, which is a little bit hard to see in the pictures, but I think it's just kind of a fun fact for you guys to have. If you look at the green pressure curve in here, or forgive me, this is the flow curve, the green flow curve, you'll see that it's green, but there's these little spikes of pink in here. So these little spikes of pink are actually where the patient is initiating their breath. So that's good, right? We're all initiating our own breaths. So if you look at a patient and you see that they're only initiating sometimes versus all the time, that should be a little bit concerning to you. So in this other picture, although it's hard to see, I think it's only 2 out of the 4 breaths that patient actually initiated, where they were just kind of riding the vent for the other ones. And then for this one, it's all pink. Again, I know this seems a little bit like you're not training to be a respiratory therapist or a pulmonologist. This is very, very important to be able to look at, because this is how you decide if they're too sedated. So you go in and they say, oh, they failed their SBT, and the team goes, okay, well, we'll try again tomorrow. You should then go look at the little screen, and if you see that there were no pink marks, that probably means that they have too much fentanyl on board, too much Midaz on board, and so you're going to be the one saying, hey, can we come down on the sedation? Can we use Precedex? Can we take them off of it for a little bit? Or another classic is they fail it, and then you go look at the MAR, and you realize the nurse gave them like 4 of Ativan, like 30 minutes prior, and it's like, I don't think anyone's going to pass an SBT on 4 milligrams of IV Ativan. You know, and so those are the types of real world things that happen. So it's very helpful to be able to look at this and kind of have a working understanding of what's happening. Okay, very nice.
I have a question.
Yeah, absolutely.
For patient 1, is the ventilator set to 12? Or are they breathing 12 feet or breaths per minute?
No, this is actually a very good point. So let me, I'm going to have to back up a couple of steps in my argument. Although I'm still going to say that I like scenario 1 because the FI2 is a P. But this is a great point. So the gray bar here is the set respiratory rate that the team wants. 12 versus 22. The team says you got to breathe 22 times a minute because otherwise you're not getting the job done. Then you can look at the green, and that's what the patient is actually doing. So in this case, the patient, his respiratory rate is 23 in scenario 2, so just 1 over what the team wanted. So, okay, but it is interesting the team wants such a high respiratory rate. In this situation, the team's like, okay, 12 is fine, you can kind of do what you want. This respiratory rate is 21 right here. The other thing that's difficult about a snapshot like this is that it really does, this number changes, kind of like when you're looking at like your car and you're like accelerating or decelerating on the highway. It's kind of like for 1 second at a time you might go up to 85, but overall the last 30 minutes you've been going 70. So the question is, do you blame the person for that 85 or is it 70? Okay. So for this, it's actually, if I was being really good, I would take you a little video and let you watch and see what it does. So in this case, is this 21 what they've been doing, or have they actually been riding closer to 15? And unfortunately, I can't tell you from this picture. But that is a great question and another very, very important thing to be able to look at on a ventilator. Okay.
So is it like good that they're breathing past what the ventilator is doing? Does that mean they're doing good? Or if it's like too high, does that mean they're doing poorly?
My least favorite answer to this question was also the truth. It depends on the patient, which I know is an annoying answer. I would say that in general, a patient that is initiating their own breath consistently, that is a good thing. We always are into patients that are breathing on their own. So I feel like that part is good. Again, the part that's hard for me, maybe this moment, this 21, like who knows, maybe they just got a sub-Q heparin shot, which seems like that would hurt a lot, so maybe their respiratory rate popped up for a second, and then it's coming back down. I think you and I would have to sit in this room and decide how we felt about it. If they were consistently breathing, you know, I would say 21 is not terrible. Anything over 25, 30 times a minute, I'm concerned. Regardless of, I want to know why they feel the need to breathe so fast. And ideally, this patient would be under 20 in my opinion. So 21 is kind of a borderline thing where I'd want to look a little bit longer. Very nice. All right.
Hi, Vanessa.
Yes.
Can I ask you another question?
Absolutely.
Okay, so I know that you do analgesia and sedation prior to doing a paralytic, but what is the indication for starting a paralytic agent?
So, in my opinion, my ideal indication for a paralytic in a patient with ARDS is to do it exactly like the Accurasis trial. And so in that, they did it for the first 48 hours. They did a set infusion, and for 48 hours they did it. And they think that why that works is that basically it might have some anti-inflammatory effects, which is good. So there's that theory. And the other thing too is that it does decrease them fighting the ventilator. And when you fight a ventilator, it causes increased pressures in the lungs. Increased pressures causes increased damage, which is more inflammation, more fibrosis, and all those other types of bad things. So that study found that if you just hit them hard in the first 48 hours, they do better. So that to me would be the most pure answer to your question. I will tell you that we've also used neuromuscular blockers in patients that have respiratory failure that are beyond that point or maybe don't have ARDS, but with the same idea in mind that we're improving ventilator synchrony. Again, this is a very invasive intervention. This is only after we've tried many, many other things, and it's kind of like a last-ditch effort. But I think that is, to me, why it's so important for you guys to know about it, because these patients are very, very sick. They're on a lot of different therapies, and now we're pulling in, to me, a very dangerous medication. So it's helpful for you guys to know what's going on, provide some rationality to the team. It's a great question as well. What else do you guys have?
I have a question. Well, I was just going back to question 7. It says where he's, I was just curious, it says he's pulling 800 mils of but we're only giving him 400. I mean, is he pulling more? Is that just like a side effect of him, like his respiratory problems, or does he actually need more oxygen when we change the settings, like more oxygen or the rate or anything?
Yes. So the question I'm getting is, this guy's pulling 800, but we only want him to get 400. Is that good? Is it because he needs it? What's going on? So this to me is kind of like why pulmonology is a specialty, why RT exists. There's a lot of reasons why this could be happening. In this situation, I guided you to the reason of please sedate the patient, but there could be other things that are going on. You could fiddle with the FiO2, go up to 70, and he stops doing that. So he needed more oxygen. Or it could be that he's in a ton of pain, and so he's like freaking out, and that's why he's pulling it. It could be that he just doesn't like the setting. Like, different patients do with different modes. So it was a very interesting experience when I was a resident. They basically let me just like hold my nose and put a tube up, and I just relaxed and let the machine breathe for me. I will tell you that I actually enjoyed PRVC, but I like pressure control better. Volume control felt super weird to me. I don't know if that's how I would feel if I had the flu and ARDS, but it is true where you flip between different modes, different pressures, different respiratory rates, and they like it better. I mean, because it is weird. You're taking basically one of the most fundamental reflexes of being alive, and now you're having a machine handle it for you. It's a bizarre experience. So it can be something like that. Some of these patients, again, their body realizes, a young patient that has such a low oxygenation, your body is able to mount a pretty incredible response. I mean, it's like, what is going on? I can't oxygenate. So it's trying its best to help you to breathe. But the problem is that it's kind of one of those compensatory mechanisms that has adverse effects. So even though it would make sense, your body, this is one of the only things it has in its repertoire to increase the tidal volume, to increase your ventilation, increase your oxygenation, it is doing bad things because it's causing more damage because of the positive pressure. So that is, to me, what makes being a pharmacist in the unit so infinitely fascinating, is trying to figure out what's going on and what works. So I definitely sat with a respiratory therapist, and they're like, we've done everything, I don't know what works. And so we're like, okay, well, we'll just go up on the sedation. Those are real conversations that happen. All right. Let's see here. So he grows pseudomonas on his BAL. He was treated for a week with cefepime. He's had downtrending leukocytosis, which is exciting. Afebrile, which is also exciting. But last night he had temperatures of 38, 38.3, 38.7. His FiO2 was 40 yesterday, but now it's 60. His peak was 5 yesterday, now it's 8. Tell me, are you going to discontinue the antibiotics or not? And tell me why. Oh yeah, double digits, group 10. Doing better or not, I guess would be the question. Let's start there. Do you think he improved since yesterday or didn't improve since yesterday?
We don't, since the ventilator monitoring is worsening. Their PEEP is on an upward trend. Wow. And their FiO2 is over 40%.
Yeah, no, I think that's a beautiful thing. So not only does this patient have new fevers, which is a little bit concerning, but now you also are saying that his ventilation status is worsening. There could be many reasons for this. Maybe he threw a PE last night. That can be a cause of fevers and worsening oxygenation. There could be lots of things going on. But I think infection, pseudomonas pneumonia, should certainly stay high on your differential of what's going on. So yes, I would continue in this case. And not only because of the 8 versus 15 day study, which says that pseudomonas should go for 15 days as opposed to 8, but also because he's still not looking that great. Again, I want you to realize that a ventilator is a monitoring parameter for antibiotic therapy. Okay, this is very important. So I don't know. I think I told you guys the story in the recording, but I'll tell it to you again in case you didn't listen. I think it's very important. So I show up, a PGY1 resident, and I'm so excited that day because I looked at the patient, and the susceptibilities say I can go from cefepime to rocephin, and I feel like this is going to be like my intervention of the day. I'm going to take him down. We're going to do some rocephin, maybe even go to augment, because that's what the susceptibilities show. They don't have a fever, which is great. Their white count's coming down. So I feel like I've done everything right. And I show up, and I'm on rounds, and I give my recommendation. And the attending was super nice, as was the resident. And I think generally I hadn't said anything too stupid up to that point, so they were thinking it was just a bad day for me. And they looked at me and they go, well, you know that they got put on Vyvanse last night, right? Like they're on APRV now. And I was like, and I had no idea what that meant. I was like, oh yeah, I got it. Yeah, so we'll stay with it. And so what had happened overnight is they had gone from relatively minimal vent settings to all of a sudden needing almost maximal oxygenation with APRV, which is pretty much the most intense level of ventilation we have before ECMO. And I had just completely not even incorporated that into my plan. And so sure enough, we did repeat cultures, and it comes back as resistant to all the things, and so cefepime remained the right choice. All right, so I'm hoping to have you avoid that moment in your life, because you'll just know that increasing ventilator support is not good, okay? So, and that could be that you need more diuresis, you need more antibiotics, you need to change your plan, your sedation isn't working right, they're getting sick, they have a PE, something is going on that you need to now assess. All right. Yes.
Would you recommend changing the antibiotic because he got better and now he's worse again? So do you think he's getting
Yes. I think that would be a worthwhile conversation to have. So for this patient, this is more of a vignette than giving you all the details. If this patient wasn't on vancomycin, I would probably add vancomycin. I would probably want to look at what my institutional susceptibilities are. Like for us, cefepime rocks. So even though they're not looking great and they're maybe not doing the awesome on cefepime, that almost makes me think that it's something that cefepime just doesn't cover, but not in a way that I need to like go to America. But technically, for Pseudomonas, if you want to go per the CAP and VAP guidelines and all such as that, you would probably add aminoglycoside for Pseudomonas double coverage. So I think that could be a very reasonable choice. But I think the big thing is you're not going to get rid of the antibiotics. So as long as we can agree on that, I'll let Dr. Bland take over on the ID perspective. Okay. So tell me about this last thing. So he's began to improve after 6 days on the ventilator. They want to do an SBT, but he fails. Why do you think the patient failed when you look at him? And what do you think you should do? Group 11. Why do you think this guy couldn't fly? So we say they didn't fly off the vent.
So we're not exactly sure, but we think it's because the input is greater than the output, so he's retaining fluid, and so we could increase the furosemide to 40 milligrams.
Beautiful, I love that. So yeah, one of the key things here is this guy looks like he's, for the net, looks like he's 7 liters positive. So that's like, multiple 2-liter Coke bottles that are now in your body, right? So that's probably not a good thing for him. So yeah, that certainly is one that we may need to diurese. What do you guys think of his set respiratory rate versus what the patient is doing? Is that good or bad? How about group 12?
Can you repeat that question?
Yeah, so what I'm kind of getting at is that for this patient, this is more in the interest of time, I'm just going to keep us moving. The respiratory rate here is set at 8, and the patient is also breathing 8. Now that could mean that they're initiating every breath, but I would be willing to put money that they're just riding the vent. So that probably means that they failed in part because they're on fentanyl and propofol, so they're over-sedated. Although this may seem super obvious to you, if I had $1 for every time I make this observation, I would be retired at this point, okay? So this is like a great moment where you're like, hey, I think it's because you have them on 100 mics an hour of fentanyl, and maybe we should, come down on that if you want them to breathe on their own. So in this situation, I would think the patient, the ADG looks amazing, which is great, but we need to get some fluid off, and we need to desedate them. All right. Let's have you guys do some CKD. We'll reconvene at 10:30.
Is there like an
Did you say decrease the propofol?
Yes, decrease propofol, decrease fentanyl. Let them breathe. Propofol works on GABA, so it's kind of like alcohol. So bad for breathing. Yes. Yes. For sure.
Is there an empiric like decrease that you would do for fentanyl or propofol to get them to a point, or like is there?
Yeah. So
You
ideally,
just take one off.
ideally what happens is that there's a spontaneous breathing trial, and you pair it with a spontaneous awakening trial. It's like the ABC and SAT study. So you keep the analgesia the same, the fentanyl, but you cut the sedation in half, and they should wake up. And then you also let them breathe.
Okay.
Whether that actually happens, that is another question.
Like not allowed.
Urine output is probably the trouble.
Not lucky.
Yeah.
You can't be lucky.
Listen,
That's
there,
not
you
luck.
can get lucky. One time I went to a wedding.
Change it to pounds and see if that's what we did.
I went to a wedding and the whole
Oh, you mean like put in 80 pounds?
Yeah.
Oh, okay. So you need to change these back then?
Yes.
Okay.
did not know anything. I said these were tidy. Like,
I will not.
do you remember that therapy?
I don't know the email language, you know what I'm saying? It'll be pretty clear.
Was that last year? Yeah.
Or if it's not,
I don't even remember.
they usually roll it out.
Yeah. And I remember like looking at my grades and being like.
All right, guys, in the interest of time, let's get rolling here. So let's do some CKD here. So 4 BPM is a 33-year-old male. He's got CKD stage 2. Now he has urosepsis, and he has some more fun things that are going on. Okay, so group 12 on day 1. How would you characterize it? But more importantly, tell me why you came to that decision.
We said they were in AKI stage F for failure based on the urine output being less than 0.3 mils per kg per hour for the last 24 hours. And they're not seeing creatinine.
Wonderful. Yes, so the urine output was like 0.1 cc's per kilo per hour or something, which is not super great. And then the serum creatinine was like 3 times baseline. I also want to draw your attention to some other numbers that we'll talk about. So one of the other numbers that we'll talk about is just like absolute urine output. So less than 400 cc's is not good. So I think that's another number that should always kind of draw your attention. We will actually use that value in real time. So let's say I see a patient and in the last 4 hours their urine output has dropped to under 400 cc's. We become very concerned. Okay, so even though it's not a 24-hour thing, that'd be kind of not good. Other things to be aware of, the creatinine clearance is like 14 or something like that, which is not ideal. And you can see that his electrolytes are not doing super hot. So his K is 6.2, his MAG is actually fine, and his FOS is 7.6. So these are kind of things where you look at a patient, and one of the things that makes clinical practice so interesting is that you can have different kind of iterations of renal dysfunction and renal failure. So you could have a high output state where he's putting a lot out, but he's not filtering. You could have a situation where they're not putting much out, but they are filtering. So in this situation, it seems like he can't filter and he can't get rid of volume. So we're kind of 0 for 2 on that. So anyway, I completely agree. How about group 13, day 2? What do you think? And why?
We said that he was in the injury stage of AKI based on his urine output being about 0.34 mils per kg per hour. And his serum creatinine was between 1.5 and 2 times the baseline.
Yes, so that's great. We had a great, good point here of kind of what do you do if they're between failure and injury or injury and risk, depending on like what the different values are. In my opinion, I think I would usually go with the worst value to show the degree of injury. I will not make it that unclear on an exam, but I think in real life you have to realize that if you're using multiple criteria, you may see someone that kind of fits into both categories. Tell me some good news about this patient. Is there anything that's kind of happened that feels positive besides that his urine output has gone up a little bit, his creatinine's gone down a little bit? What's going on with those other things? Group 13, I guess.
It looks like his potassium is trending downward as well as his serum creatinine, so it looks like he's improving overall.
Yeah, I would agree with that. I like that his K and his phos are coming down too. So to me, that kind of speaks to we're getting some little filtering back. Creatinine clearance still doesn't look super hot, but maybe moving in that direction. I do think it's interesting to kind of look. You can kind of see, maybe look at these bank levels a little bit, and we'll kind of get to that more in the in day 2 to day 3 to kind of see like what he's clearing with bank. I actually think this is a very interesting way of being able to look at a patient. So I've had patients with a creatinine of like 3.8 that I'm scheduling vancomycin daily because they're clearing it. And so it's kind of a weird picture where like, so creatinine is taking a long time to get through it. Maybe their urine output isn't phenomenal, but again, they're getting through their bank. That to me speaks to like there's some function coming back. So again, a lot of times it can be a mixed picture. All right, day 3. What do you guys think? 14.
Well, the patient's definitely improving. According to Rifle, guess he's no longer in AKI state at all. Potassium looks great. Serum creatinine is just above where the baseline is of 1.4, now rating 1.7. Phosphorus is good too. It's not quite normal, but 6.1 is good enough for this patient relative to what they were going through. Yeah, so I think that the patient is definitely rapidly improving there.
I agree. So I said officially out of AKI territory, still not back to baseline, but improving quickly. Those were my personal notes. So I want to be clear to myself, hey, he's not completely where I thought he'd be, but we're looking good. This is a day where we're going to start maybe making changes to antibiotic therapy in terms of dosing, stuff like that. I think, one of the things to look at too is, again, he's not completely clearing that bank yet, but he's moving, so I think this is good stuff. And I know this feels very qualitative, but this is really what you get paid the big bucks to kind of make a decision on where you think their creatinine clearance is and what you think their kidneys are doing, and then have to decide with antibiotics. All right, so based on all of this above, what are we at? Group 15, 16? 16, tell me what dosing you want to do. Tell me all 3 days. What were you going to do on day 1 versus day 2 versus day 3 for the Zosyn?
Based on the creatinine clearance, how we calculated, it would be the same dose every 3 days, which is 4.5 grams every 6 hours.
So when I look at it, I agree with you there, in that if you just use straight creatinine clearance, you can maybe justify a higher dose. However, when I see this patient on the first day, he's put less than 400 cc's out, his urine output is almost non-existent. To me, that's really a creatinine clearance of less than 10, kind of no matter what you calculate. So for a patient like this, he would to me he's almost like a dialysis patient at this point. He's not putting anything out. I would probably put him more in a 4.5 Q12 kind of picture. Because, again, the urine output is really telling you we're not in a good place. So we use, what's hard is, we'll say if you meet kind of Rifle criteria of failure or close to failure, you'll often see we'll just go with the less than 10 dosing. I will tell you this is a little bit more of an art than a science, but I do think it's very important because this is the kind of decisions that we're making every day. To me, day 2, he's starting to look a little bit better. I think you could make an argument for keeping him at Q12, but I also think you could convince me of Q8 because his urine output is improving. His creatinine did downtrend significantly. And let's see, if you do the poor man's creatinine clearance, if you've ever done this, you can do 140 minus their age divided by their creatinine and just not even include the weight. So he's at, what is he at? 2.6, which puts him even into the 40s range if you just do the kind of 4 minutes creatinine clearance. So I think for that, you could convince me of Q8. And then by the last day, you know, he really is rapidly improving. You know, I think again, I would probably keep him on the Q8 range. The Zosyn, I mean, the lack of vein clearance kind of makes me a little bit nervous. But I think you could potentially say you want to go with Q6 in this situation, given that his urine output has come back, that his creatinine is downtrending, his electrolytes are clearing, stuff like that. So for this, what I want you to realize is that the way that I would trick you on an exam, and I will try to trick you in this way, is if they don't have a good urine output, you got to pick like the less than 10 value, okay? Because that basically is saying that they have such bad failure that they basically are like a dialysis patient. They're not clearing anything. From there, that's, you know, step one. From there, whatever you calculate as the creatinine clearance, that's a good answer from an exam perspective. I also want you to take away that in real life, many pharmacists, especially in the ICU setting, do not go straight by the table. We're looking at all the other things, trying to say, what do we think is going on? And the reason why we're doing this is because this table comes from basically like healthy adults, okay? So these patients don't have a weird high volume distribution, they don't have a hypermetabolic state, they're not dying of sepsis, all those types of things. And so always in an ICU type setting, especially for a patient like this, we're probably going to err on overdosing as opposed to underdosing. So like what's the worst that can happen with a patient on, you know, a beta-lactam antibiotic? You know, I guess Zosyn has a little bit of AKI. It can't be worse than what we already have here, right? So I mean, we're using Zosyn, it's because we have to. So then we have what? Allergies, some diarrhea, nothing super exciting. If you want to get into it, you might think of seizures for beta-lactam, but not, I think all of those things are probably less than like dying of sepsis, right? So I always say untreated sepsis is definitely worse for your AKI than any antibiotic that you can give them pretty much, besides like Colistin or something. So anyway, again, always look at that urine output, because to me that's a big trump card. And also realize in real life you may or may not actually use the table. All right, patient case 2. So kind of what I wanted you guys to do is look at, this is to me a very, you know, classic patient. They come into your cardiology service, but they have this history of end-stage renal disease, and they're on all of these medications. They're getting initiated with amio, they've got this vest now, and you're kind of in charge of figuring out what's going on with these meds. So for me, this is very typical of my life, where I'm not a CKD or a renal pharmacist, but I deal with a lot of these patients in another setting. And so I look at it like, wow, this is a huge list. It's always the characteristic to me of a CKD patient is they've got a ton of meds. So to me, I think what would be helpful is to kind of understand what is each med for, where are you going to put it, and what are we going to do with it. So, where are we at? We did group 16? How was you guys, right? How about group 17? Tell me about neurologic. What drug are you putting under neurologic? Are you concerned about it given their CKD? What are we doing?
We put gabapentin under the neurologic, probably because he's experiencing some neuropathy from his diabetes. And then based on his creatinine clearance, it needs to be adjusted. He's taking way too much.
Yes. All right, so I had gabapentin. Were you quick at the thing?
Yeah.
Okay.
I don't know if they heard me though.
Okay, so we have gabapentin here, and we're talking about whether or not we need to renally adjust it. So this is kind of an interesting moment from I agree with you, according to Lexi, this is like way too much drug. That is definitely true. The question is, basically, the biggest thing we would be concerned about is if he's having drowsiness, right? That's pretty much like what gabapentin does. If you take too much of it, is you become drowsy, alter mental status. So let's say he tells you, I have been on gabapentin 1200 TID for 4 years. It works amazing. My neuropathy's gone. And he's talking to you like that. Are you going to decrease his gabapentin?
No.
Yeah, the answer should hopefully be no. So I want you to be thoughtful about that for gabapentin. To me, this is a drug that you can titrate up. If the patient's not experiencing symptoms, I'm not sure I would change it. So I think that's something very, very important to realize. Also, again, if the patient's not experiencing symptoms, I don't want you to become like a super stickler for like the creatinine clearance is 59 versus 60, so I got to make some dose adjustment. I want you to look at your patient before you make that dose adjustment. I do agree with you that if the patient starts to act a little funky, we definitely need to look at the gabapentin as the smoking gun. But I'm not necessarily, it wouldn't be my first intervention personally. Just kind of something I keep in the back of my mind. But yes, I agree. Diabetic neuropathy, gabapentin goes under neuro. We're going to watch the mental status and see what happens. Okay, so it looks like lucky group 18 has to tell me everything going on in cardiovascular. What is going on with this poor patient? So what's one of the drugs under CV that you would classify? All right, group 18, group 19, who wants to help give an answer? What do we think? All right, I'll give you one. Metoprolol. Stage water, usually involved with the heart. Why is this patient on that?
Heart failure?
Yeah, heart failure. Beautiful. Okay. What are you going to monitor?
Heart rate, which is high.
Heart rate, which is high. So multiple reasons his heart rate could be high. Heart rate usually goes up when the body is kind of compensating, trying to keep your blood pressure up. So it could be just that he has bad heart and his heart doesn't beat all that great, so it goes up because it's not doing all that well from a contractility perspective. He's also a little bit anemic, so maybe he's struggling from that perspective. Maybe he's just freaking out because he fainted in the dialysis clinic. That doesn't sound super exciting, so a little bit of a catacomnia response. But that's nonetheless what we would look at. Okay, I feel good about that one. What's another CV med?
The amio.
Amiodarone, beautiful. What are we going to follow with amiodarone? EKG, absolutely. He had, what did he have? He had some kind of arrhythmia. That was exciting, right? So VTAC. So definitely going to watch for that, right? That's a life-threatening arrhythmia. What are other fun things we need to follow long-term with a patient on amiodarone?
Ocular, thyroid.
I'm hearing all the things here. So yeah, like LFTs and pulmonary and eyes and all the stuff. So amiodarone pretty much affects every disease state. There's some great pictures. If you Google amiodarone side effects in the body, it shows like this little body that has like all pieces. Just, yeah, look at that. That would be great. Let's see. How about lisinopril? We got group 20. What's that for?
Heart failure and hypertension.
Yes, and CKD, right? It's like a three-fer at this point. So, you're going to monitor what the usual, right? Serum creatinine, potassium, blood pressure, all that good stuff. Tell me about the spironolactone. Who feels good about having spironolactone on a CKD patient? Is that safe? Group 21.
I don't think so.
Yeah. So if nothing else, I'm doing a mean trick to you. So one of the things you learn as a resident is they'll ask you a leading question. Well, what do you think about that? And they're asking, they get pretty angry, so you're like, oh, it must be bad, right? So I kind of what I did was I made my voice sound like that just to lead you to that. It's actually fine to get it in CKD. So, but to your point, you probably hopefully have concerns about using a diuretic, potassium-sparing diuretic in a CKD patient for high potassium. That would make sense, right? We don't want the patient to have hyperkalemia. Also, does it actually work to make them urinate if they have CKD or ESRD? That would be another $1 million question, right? But the big thing here is that spironolactone, when you're using it in congestive heart failure, we're not using it as a diuretic. We actually don't care about its diuretic properties at all. We care that it's an aldosterone antagonist, so it has to mess with the RAS system. It does all these things for cardiac remodeling. So it actually doesn't matter to me at all that it doesn't work as a diuretic. I don't really care what happens with potassium as long as it's not high. So they've actually done some studies that have shown that spironolactone in heart failure patients in ESRD is safe. You can do it, and we will do it. But to your point, we should probably monitor potassium. So please monitor potassium, but also continue this spironolactone. Alrighty. What was the other CV? I thought there was one more on here that was interesting.
He's on a statin.
Oh, a statin. Yeah, what's a statin for? He's got so many good reasons to be on a statin, right? Yeah, exactly. Yeah, he's got diabetes. It reduces CV risk. I'm sure if he did his Framingham, it would be through the roof. So we'll keep him on a statin. Is there a potential drug-drug interaction we need to be concerned about with the new start med? Like an IPC pulled up for you guys. Technically, amiostatins have a little bit of interaction. I would keep on a statin. If he has an increase in LFTs or something, we can go from there. But I'm all about the statin game. All right. Let's see here. Let's talk about endocrine. What group are we on? 22. What drugs would you put in the endocrine category? What were you looking at? Or we can do phone a friend. We only have like 6 minutes left.
Insulin.
Yes, good job. Yes, I have insulin here. Insulin is an excellent endocrine medication. Okay, so what are we going to monitor with insulin glargine and aspart in type 2 diabetes in a CKD patient? His blood sugar. Yes, that's always the answer with insulin, right? What else would you monitor? But in particular, why would you be maybe intrigued by insulin in a patient that has CKD? Is renally cleared. Insulin is renally cleared. So one of the most bizarre things that happened to me, I did for one of my APPs, I got to do the renal transplant clinic. And so, and the pre-cover totally set me up for this one, which is why I'll never forget it. And she goes, what's the patient's home beds? And so I'm listening out the home beds, and it's kind of like I listen them for all statin. They had a transplant, so they're on TAC and prednisone and stuff like that. And she goes, okay, what was the cause of why did they need a kidney transplant? I was like, oh, they had diabetes, type 2 diabetes, for sure, that's what's going on. She's like, okay. She goes, why are they not on anything? And I was like, oh, I don't know. And I felt really bad, like, it's so obvious. Like, type 2 diabetes, probably going to be on a diabetes medication, right? Probably going to be on insulin in particular. And I looked at the blood sugar, and it's fine. And she's kind of giving me this cute little smile. And I was like, I don't understand. And she goes, well, what's interesting about patients that have transplants and then pre-transplant workup is that you can actually, the CKD, which they got from their diabetes, actually cures their diabetes because they can't clear insulin. So you actually have longer circulating insulin. So what you'll see is they have like terrible blood sugars, lots of insulin needs, their kidneys go down the tubes, and so then they have almost no insulin requirements, and then they can get a transplant, and you can actually see their insulin requirements go back up again as their kidneys start to work, which is very interesting. But nonetheless, that's all that there is to say about that. Okay, this guy also has some interesting things going on in endocrine. Let's see, what kind of values did I give you guys? What's his vitamin D level? Tell me about this vitamin D level. Is it good or bad? What are we at? 24? Or anyone? Is it high? Is it low? Should we do anything about it?
It's low.
It's low. What do you want to do? So for a patient like this, vitamin D is like, you know, it's a nice thing to have. It gets rid of your seasonal depression, right? It's good for immune system, good for bones, good for all that good stuff. So if the patient's level is low, to me it would make sense to replace it. So I would just kind of keep in mind, I personally have to look up vitamin D levels every time in a chart. So although for you guys, it would probably be helpful for you to kind of have a working understanding of like the general vitamin D dosing. This is something that's helpful to know, okay? I'm not going to peg it too hard on specific dosing regimens, but I think it's nice to know that generally speaking, when you're doing replacement in a CKD patient, you're going to be doing those, 50,000 a week little green capsules. That's going to be a thing, okay? Alrighty, what else are we going to do? This patient also has secondary hyperparathyroidism, right? So we would know that because they have a high PTH, they have a high calcium, they have a high phosphorus. So the question becomes, what do we want to do for this? So in a patient like this is probably somebody who we're not going to fix all of their life problems on this admission. They're probably someone you're going to see in an amp care type setting. You're going to try one thing, it works or doesn't work, they come back, you do another thing. The things that I would be thinking about would be, one, is it a simple fix, like they just need more phos binders? Where they just get rid of more phos, is helpful. Vitamin D supplementation is also going to help with that. And potentially they need cinecalcet as well. So I think that would be kind of the process where you're thinking through like what do they need, kind of hopefully in a somewhat stepwise fashion. All right. From a hematology perspective. So the key thing that I think is important to take away is EPO kind of is like the whip saying, get going, let's make some more. If you don't have the building blocks to make more red blood cells, the EPO is not going to do a lot. So always the team's like, we need to give EPO. EPO sounds really cool, it's doping, all that kind of stuff. They know about EPO, but do they realize that it's kind of like the little things like folate and iron and all of that that you also need to give? So I always find that for me, they always say, what's the dose of EPO we need to give this patient? And I say, I don't know, I'm going to have to look that up because I do not keep EPO on lock. But then while I'm doing that, I always say, have we gotten any of these levels? And usually that buys me enough time for them to go, oh, I don't know. And then I go look it up, and by the time they've looked it up and I've looked it up, we come to an actual plan, okay? So for this patient, it would seem that they probably need some type of supplementation both on the iron level, the folic acid level, and potentially the B12, okay? So you can definitely give them some EPO if you desire, but if they're having resistance, you always need to look at those levels, and it's probably a good idea to just do that at the outset. All right. I also had these little mini questions at the end. For 5 minutes, I'm just going to kind of tell you about it, and to me, what I think is important to realize. So for both the ANSEP question and the Kepler question, I think what's interesting is that for these, you actually have to time it potentially with dialysis, which makes things kind of intriguing. So in a hospital setting, one of the most difficult parts about my life is that I have no clue when the dialysis people are going to show up. So it's very hard for me to be like, I'm going to give this dose after dialysis because I don't know when that's happening, and the nurse just wants to know when to get it. So what you'll find is that a patient that is on, 3 times a week dialysis in an outpatient setting might get the dosing after dialysis. So like you'll see, like for them, if they were getting bank, maybe they're going to get 1 gram of bank after dialysis. They're not really checking levels because they know that it works. They'll get a couple levels in the beginning, know that it's good, and then it's just every time after dialysis they get bank or something like that. Whereas for me, since I'm not entirely sure when they're coming, nor do I know just because they're Monday, Wednesday, Friday, maybe they're fluid overloaded on Thursday and we say we got to do it on Thursday, I have no ability to predict that. So a lot of times the dosing in-house will look a little bit different. Similarly with Keppra, this is another one that you will see where officially it's, a gram every 24 hours and then you give the supplemental dose post-hemodialysis. So this is one that we do see in-house, and it's a little bit easier to do, but it's also that I have to ask every day, like, okay, did you do secret dialysis on me, or are we truly on Monday, Wednesday, Friday? So we usually do their, whatever their standard dose is in the morning. They go for dialysis at some point, and we'll put their second dose in the evening, way late, like 10 o'clock at night, because we're hoping the dialysis happened by 10 p.m. that day. But then it's a good thing always be looking at your notes to make sure that they didn't go and get emergent dialysis. Similarly for a patient that's maybe having seizures, they're not on dialysis all the time, but they get it at night, and then you have to go back and look at the meds and say, is there anything I need to supplement? So just something I want you to be aware of, that you need to go look at that when you have patients that have CKD in-house, because the plan changes, and you have to be able to adjust the doses based on all of that. All right, thoughts, questions, concerns on today? All right, with that, you have 2 minutes of extra freedom. So you guys are backing with me in